Can you introduce yourself, please?
Hello, everyone. I am from National Taiwan University Hospital. I am currently the coordinator for AADC Deficiency patients. My name is Li Mai Xin. My English name is Ariel. Here, you might seldom hear about the role of a coordinator in a hospital. But in the hospital, you often hear that it's kind of like a case manager, research assistant, or a research nurse. A role like that. It's just that this coordination includes case from research to clinical aspects. We may need to help with some comprehensive holistic planning and some care management processes. In this process, it involves interdisciplinary cross-team parts. So the so-called interdisciplinary includes, most of us would go to the genetics department. But in fact, these patients may also need to see orthopedics, physical medicine, and rehabilitation, dentistry, psychological counseling, and psychological therapy. And we also talk about nutritional counseling. These various departments may all be seen. So in such a process, there will be a problem with AADC deficiency. It's rare because it's a rare disease. So most people may not have the opportunity to get in touch with it so quickly. So I will assist them to explain what this disease might need help with or what needs to be noted, and to do some coordination in the middle.
How did you first get involved with AADC deficiency?
My first contact with rare diseases was in 2006. But at that time, I didn't directly come into contact with AADC deficiency cases. It wasn't until 2014 that I came into contact with my first AADC patient. But that patient was a bit different from what we might read in textbooks, because his growth and development were not much different from his actual age. And then in 2015, I started my current job. But because of what we just talked about, research. So in there, I play a role similar to that of a research nurse, to assist, including how these patients should undergo gene therapy, what preparations we need to make before gene therapy, during the gene therapy process, and some follow-ups after gene therapy as well. And so it has been until now. But over the past few years, I've noticed that although it's also because of gene therapy, we can clearly observe the patients before and after treatment, and the families, the challenges they face. So in this part, you should be detailed, right? Do you want to ask?
How many AADC deficiency children have you worked with?
Okay, currently speaking, because we have a rare disease notification system here in Taiwan, up to now, the number of people notified for rare diseases has reached over 60. However, among these over 60, some children might be in a weaker state due to the disease. So they might have already passed away. And then some of them may still be ongoing, including, as we mentioned, newborn screening. They have been screened, and then it is known that they have this disease. Now they continue to be taken care of. Looking at the overall situation, currently I have actually been in contact with and regularly follow up on about 50 families like this. And then there's the matter of,
what inspired you to focus on this rare disease and provide so much time and energy to the children and families affected by it?
It was back in 2006, because up until now, I have actually been in contact with rare diseases for a very long time. Of course, different rare diseases pose different challenges when it comes to care, but AADC deficiency for me, has made me feel like I'm looking at possibilities again. It's like because I originally studied nursing, and then looking at such a disease and families, you observe a few things. For instance, these children, although according to what we read in textbooks, they might just be lying there, and they might not be able to eat or drink. Even their sleep is not stable. They all require assistance. But you will observe that actually, these children still have quite a few expressions, including every time they come to the clinic. After I finish explaining to the family, I would go to greet the children to check on their current condition. But when confirming their current condition, it would be based on their actual age. Interact with them and see. And you will find that these children have very subtle expressions. And it is because of this reason that I discussed with the physicians on our team, including Dr. Hu, and had a brief chat with him to see if there are different aspects where I could improve the care. And that's why we feel that although we have done an intervention with gene therapy before the treatment, these families or these children may have some things that we need to pay attention to and deal with. But of course, after the treatment, there are still some things that must be continuously followed up and dealt with. But it sounds like these two paragraphs are the same. But because of some of the information we found online, the disease information we talk about, what we see is, actually, when family members face these diseases, it's more like what we talk about. It's a more hopeless part, because it seems that the child might only live until a certain age, and then they might leave us. But in reality, over the years, we have taken care of them like this. And also, that is to say, after getting to know each family more deeply, we found that what might be written in textbooks, it must be the most severe cases. And later, because of this, we further understand, because AADC deficiency is what we're talking about. It's just that they lack the AADC enzyme, leading to these subsequent problems. But actually, the most important thing is his muscle coordination. It's very clear. It's not performing very well. So you often see these children, because our muscles are all over the body from the inside out. So just to go, maybe like I'm sitting here now, to hold my own body, and even just talking for such a long time. Then breathing also needs to be coordinated. These things are necessary for these children, to do it in segments. So also because of poor muscle coordination, they may not have had better training. And if you don't do a good job training, then before treatment, if you just let them lie there, they will clearly have a symptom we call OGC. It's oculogyrate crisis. When this oculogyrate crisis occurs, they have a lot of strength, but they usually don't coordinate well when this strength comes out. They start to move around, then one moves around. Actually, if I were the family member and I went to see him today, I might not know how to take care of him. And even then, I might just spend my day feeding him, giving him water, and putting him to sleep. It might take a lot of effort and time. I might not be able to interact with the child calmly. So, it's also because of gene therapy, after observing the changes before and after. Our current approach is, before gene therapy, we ask the family to first take care of the child in a usual and ordinary way. That is, when to eat, when to drink, when to sleep. We first establish these good habits. As for the part that people often talk about, there is a part that people often mention. AADC deficiency seems to be due to a lack of some things, like the serotonin we talk about, dopamine, and these substances, which may lead to some emotions or some issues. So we also encourage parents to help us observe another thing. That is, when we provide enough general human interaction, is it possible to increase the cognitive stimulation for these children just a little bit to make them more familiar with the environment? Then there might be a chance to be clearer. That is, maybe what is written in textbooks will not be the same in the future. That's also why the children before gene therapy now are beginning to slowly, that is, family members are taking them out. We have even started to organize some activities and courses so they can go out and stay overnight, these kinds of things. What we look forward to is, during the treatment, these are some of the pre-treatment care. And after treatment, it's about continuing what was before the treatment. Of course, it means whether everyone after treatment, suddenly I might not be able to stand up and walk or start to tell us to speak. Just like I mentioned earlier, breathing, speaking, maintaining posture, all of these are very, very challenging for them. So we are also observing to see if there is anything that could assist them. A way that is not so strenuous, slowly training them up. But because of this area, it actually involves quite a lot. Not only the support and involvement of the family, but you might also need, like we said, physical therapists, occupational therapists, speech therapists, in addition to special education teachers, people from all kinds of professions in society to assist them together. Only then might they slowly be able to, we talk a bit like integrate these learnings into their lives. But many early treatments separated therapy from daily life, so we hope to integrate them. Considering all of the above, it is actually because of AADC deficiency that attracts us to observe this aspect of humanity. For example, when should one roll over? If I don't do it properly and practice this movement well, I might not be able to do the next thing. These children, in fact, have many expressions. I'm not sure whether I am helping them or they are helping me, but through this process, I feel that I have learned a lot because we see the infinite possibilities in children. And your interaction with them is very, very rewarding. So I hope that through my small efforts, I can help them. But more often, actually, they provide our team with more help because we get to see many different aspects.
What is the most difficult part of your job?
The most challenging part of this job is to say, for the first child, speaking before the treatment, they would just lie there, not moving much. And then it might be that they can't tell us what they need. So at this point, this is the child's part. But because the child is so small, the most important is the person who takes care of them. And the person who takes care of them, most of the time, doesn't have that much time to do more things. It's because just feeding him water and food, and maybe not even being able to sleep well at night. So actually, at the very beginning, when I first came into contact with this disease, I couldn't imagine what it's like for a caregiver who can't sleep well. Watching that is quite heart-wrenching and sad. This makes you feel that even though they might have been given sleeping medication to lie in bed for an examination, but as soon as they are put down, they wake up. Waking up like that, I'm just faced with a 30-minute check that takes so much time. But back at home, they might not have slept well every night. So, in fact, is the child really that difficult to sleep? I think this is something I spent a lot of time on when I first started in 2015. My biggest hope was that I felt my wish was for the caregiver to be able to sleep well. But this matter has been going on for so many years. It seems there's still no way to achieve 100% of that. But we have been trying to slowly move in this direction. Of course, there are some changes in the way we care for them. It might be a reconstruction of a method closer to what we usually talk about, educating children, and let them have a better chance to get some good sleep. Of course, many people will also think that it's because of this gene therapy that I can sleep better. There might be some truth to that as well. It's just that what we hope is that it's not necessary to undergo gene therapy to be able to sleep well. It's about improving the quality of life for these families even before gene therapy. There's an opportunity for it to gradually improve. And if, by chance, their physical condition allows for a more intensive treatment that we call gene therapy, if it's a more invasive type of gene therapy, then isn't there a chance that 1 + 1 could be greater than 2 and give this child and their family the opportunity to return to a lifestyle that's closer to what we typically consider normal and enhance their quality of life? This is what we hope to achieve. But currently for me, I find this relatively challenging because during outpatient visits, we may only interact with them for a half a day, at most a full day. But most of the time, I feel fortunate to encounter so many families willing to share with us the difficulties they face in caregiving, so we can better understand these families. But no matter what, we are not with these children all the time. So it becomes a situation where when we might want to assist them to gain a deeper understanding, I feel that this part is a bit challenging because you might not be able to fully immerse yourself in their real life. So we really need more caregivers from the family to tell us what they've encountered. We might have the hope and opportunity to synthesize this information and possibly design the most suitable care approach for AADC. A care method like this.
Can you share with us one story that you are most proud of?
It should be said that with my previous work experience and up until now, returning to the clinical aspect, we can slowly build up the care. But I personally feel that I have interacted with some, that is, the outside. Whether it's the medical team or the educational team, when engaging in contact and cooperation, they are actually very willing to take care of families with AADC deficiency. Of course, it's not just families with AADC deficiency. They may have many families with special needs children, and they are very willing to take care of them. But they feel that, in fact, in Taiwan, I think the environment is relatively friendly because everyone will try to understand what is being done. So this year, we did something. It's that we worked with a special education school and the teachers there to have some discussions on cases, share some experiences. In this process, including people on our team, they said that's how people in the education sector might think. And the school teachers as well. Because through our sharing, they then apply what we've seen to the cases. That is, to the children. They feel that it can actually be done this way. And we feel that because, actually, the time spent in the hospital is usually very, very brief. It doesn't take up much time. But more often, these children, besides being at home, might be at school or at a clinic outside for treatment. So we really hope that there's a chance to let more people outside. That is, teams outside of our team, including those at the hospital or the clinic, or even school and society, to understand. The disease is not just as described on the internet. It seems like it's best not to touch it at all. That can be very alarming. What we hope to create is an environment where people are more willing to approach them, even to interact more. you'll find that these children really wish someone would talk to them. That's what we're looking forward to. It's about creating a very suitable environment for AADC.
In your opinion, what does the future look like for future AADC families?
As everyone mentioned earlier, it's actually been a relatively short time since the disease was discovered until now. We are relatively fortunate to have, in such a condensed time, a method to diagnose it, and also a way to treat it. But we are also very clear that most of the time it comes back to the level of care we speak of. Because to do a good job in caring for them is not that easy, because our lives are very, very busy. So we hope that in the future, for these families, after hearing about AADC, it's not just about seeing how long they might live or whether they might have slept well at night, but to see them as regular children and even to interact and understand. And to see if there's a chance that after such a shift, there might be a chance for these children to not just be confined to lying in that bed and then placed in that stroller. It's a very simple life. What we look forward to is these children being able to go out and not be so tense the moment they go out, regardless of whether they have undergone gene therapy or not. But what we hope for is that both the child and the caregiver need to relax in time and can interact better with society.
What are your future goals?
Coming back to this part, it means we have an AADC care team at National Taiwan University Hospital. Although it sounds very large, people might think there's a lot to do. But in fact, there are still many aspects that we need to continue working hard on. Over the years, we've observed that initially what we saw was this first aspect. But as time slowly passed, we found that there seemed to be some things that didn't align with what might be written in textbooks. Or even if they do align, there might still be some ways to assist these families, to make some different transitions and changes. So it's the same. We hope that this care team can become better and better, potentially getting closer to each family. Getting closer to each family means it may not necessarily be 100%. After all, each family has its own story. But what we hope is that when faced with the impact of a disease, or any shock, or some worries, we have the capability to help them. And we also hope we can increasingly understand this disease and then take better care of these families. Of course, that is to say, we actually consider every family as part of our team, because our goal is to take good care of the child. So if it relies solely on the medical team or the educational team's efforts, it won't be enough. Because the family members at home are also very important. So what we look forward to is the patient's family can view the medical team as a partner in collaboration. Not just that the medical team is the medical team, the school team is the school team, and home is home, but rather a more harmonious situation What we hope for in this society is that in the future, when hearing about AADC deficiency, it's no longer just a worry about the length of his life, but to give his life depth, as we speak of. It means they can sort of learn more and more things and grow up happily. Thank you.